OBHealthy, Physicians Health Network. We are a group of Black physicians here to do two things. Number one is to improve the health of people of African descent. Number two is to encourage Black males to go into medicine and become doctors. Our webinar is every second Saturday at 1 o'clock Eastern Time. We encourage you to let everyone know. So join us. Prior webinars can be viewed via YouTube. So just go on YouTube. Don't forget to subscribe though, so you'll know what's coming up in the future. We're here to answer all your medical questions, and the questions will be coming up and we will, under our questions and answers, and we will look at each one and try to answer each and every one of them. All right. We're going to try to keep the big words down so that each and every one of us will understand, and at the end of it, we'll have a increased knowledge of their medical problems, or how to solve, or how to be, a better health consumer. Let's call it that. All right. Let me introduce the doctors that are here today. Now I'm going to introduce them as they appear on my screen. All righty. Dr. Fredericks, please introduce yourself.
Hey, good morning. I'm Dr. Dwayne Fredericks. I'm a bariatric surgeon. I practice in South Orange, and I now primarily do medical management for obesity, because we know it's such a problem that sometimes surgery may not be able to handle it at a particular time. So I'm here.
All right, thank you. Dr. Kevin Clark.
Hi, good afternoon. Dr. Kevin Clark. I work at the Newark Beth Israel. I'm a surgical oncologist. I take care of cancers of the breast, soft tissue, colorectal, and glad to be here with all these distinguished gentlemen. All
righty. Hold on just for a second. I did something that clicked me off. Hold on. Let me click back in. There I am. Dr. Trevor Atherley.
Good afternoon, everyone. I'm an interventional cardiologist. I'm predominantly in the SS County at Newark Beth Israel Medical Center, and I'm a member of the teaching faculty there. Good to be with you.
All righty. Dr. Stratford.
Hi, Terrence Stratford, oral and maxillofacial surgery. I'm here to answer any questions you guys have. I'm glad to be in this distinguished group of gentlemen here, and just wait to hear your questions.
All righty, excellent. And Dr. James Court, please.
Good afternoon, this is Dr. Court. My specialty is internal medicine. I practice in East Orange, New Jersey.
All righty, thank you. Dr. Patrick Anderson.
Welcome everyone, glad to be here. I'm a gynecologic oncologist, meaning I take care of cancers of the female reproductive system. I work at Newark Beth Israel with most of the distinguished docs on this panel, Dr. Atherley, Clark, Omar Bey, Dr. Court. Glad to be here.
All righty. And Dr. Nelson Aluya.
You're muted, Nelson.
All right, sorry. Yeah, good afternoon or good morning, wherever you are. It's a pleasure to be here once again. My name is Nelson Aluya. I'm a Nigerian-born physician, assistant professor of medicine at New Jersey Medical School. Also an attending physician at the Newark Beth Israel Medical Center, where I work with some of the great doctors who are here. It's a pleasure to be here. But before I go, a great permission from Dr. Omar Bey, who's the brain behind this. I want to typically say thank you to all the doctors, Dr. Anderson, Dr. Fredericks, Kevin Clark, Dr. Court, Trevor Atherley, and all the other people who've been doing this for quite a while. I gave a little story the other day before the COVID hit. We used to go from town to town, city to cities, doing this. And very rarely have I met a group of individuals, doctors who have given their time, no matter how busy they are, to find time to do this, to come together to share information and love for the community which they serve. I must say a huge thank you. The last time we did this on a face-to-face was when we went to Staten Island, New York, which was one of the days that it rained cat and dog.
It was really raining, yes.
So, and that's the commitment that they have. And I must say, you know, if I haven't said it once enough, please, I appreciate you all, and I thank you for what you're doing. And thank you, Dr. Bay, for helping to put this together. Bless you.
Right. Well, that was unexpected. Thank you very much. I try to keep myself low key. Yeah, I have so much brain power here that you know, we're just so appreciative. All righty. Let me get back to the ground rules. This is so important. All right. Don't change any aspect of your medical care until you consult your physician. I don't care what we say, because understand we're all different, and your physician is the best one to know the proper medical care for you. So do not change. All righty. And so I think that's it. And I think what we need to do is just get going and ask some questions here. All righty. The first question is, and it comes from one of our doctors, Dr. Hudgens, and her church is always keyed into what we're doing. And it comes from her church. And basically, it's about migraines. And we just want to cover that. What is a migraine, number one? Number two, what can we do about them? Number three, is it hereditary? Let's talk about migraines at this particular point. Can we start it off with Dr. Court? Can you help us out with migraines?
Thank you, my friend. Migraine is a condition really that affects anyone. There are usually 4 phases of migraine. It begins with a prodrome, where the patient will start to yawn and have some food cravings. Then the next step is followed by what is called an aura, where they may see or hear or different things. Then the third step is the actual headache itself. And the fourth step is called the prodrome. Prodrome is a period where after the migraine, they feel drained, they feel exhausted, and they can't wait for the next one to arrive. Typically, it's seen mostly in females. It can be triggered by several different things: stress, menstruation, certain smells, things like chocolate, and other things that can affect the person. That's my introduction. I'm sure my other friends will chime in terms of what else. That's an overview of really what goes on.
Right. Thank you, Dr. Court. Is there anyone else that can give a different flavor from their specialty?
Sure. I will just chime in for a second there. So what we've noticed is that with TMJ, just temporal mandibular joint disorder or disease, however you want to call it, what it does, it's a trigger. It's not the cause, but it's one of the triggers. And that trigger, just as Dr. Court said, is that yawning. When you yawn, that clicking, and it's exacerbated or it's initiated by stress. That stress could be physical, environmental, emotional, whatever it is that we can't quite handle. And then what the jaw does is it begins to grind. You start to find this clenching when you're driving, or you're grinding when you sleep. Your spouse wakes you up, says you're grinding too much. So what happens is that it causes a muscular inflammation, and that muscular inflammation starts to exacerbate or to trigger the migraine, which goes into, we don't know why. They'll usually come to a dentist and they'll say, listen, you know, all my teeth hurt. I have the earache that doesn't seem to go away. I have water in my ear. And so you're talking to them because they're saying, you know, I think I need a root canal because my tooth hurts so bad. It's so sensitive to hot and cold all of a sudden. But that's from the constant grinding. It's taking the ligaments and the structure within the teeth, and it's creating a response that causes the jaws and the muscles to become inflamed. And once they become inflamed, then it starts to become that trigger to the migraine and all the other things that I just talked about. So the only thing that we do in dentistry is we try to treat it palliatively. We try to treat it conservatively, because the surgical intervention doesn't ever seem to work very well. So we try to stay right at that level and try to first identify what is that trigger? What is the thing that caused you or that stress level that pushed you over that point where you started to grind and clench, and then next thing you know, one thing leads to another, and then all of a sudden you have teeth problems that are hurting, sensitive to hot and cold and so forth. And that's where I think, Dr. Court, you have to take over from there.
All right.
Dr. Stratford, can I ask a question?
Yeah.
Some people say that using Botox in that region helps. Do you see that?
Yes, I do. It absolutely does.
Mhm.
For a limited amount of time, but it definitely does.
Because it relaxes that muscle?
Yes, and that starts to decrease that whole trigger event.
Excellent.
So
But you would have to,
a lot more of it.
yeah, you would have to get repeated treatments though with the Botox, right?
Yes, you do.
Okay.
But
All right.
but it helps relieve that symptomology.
Right.
And
Right.
gets the patient back to where they can try to begin to identify that stress, because it's really identifying what that is, finding out what that one thing is, whether it's a job, or a new relationship, or whatever it is. And once you begin to focus on that, so it's kind of a multimodal approach, because you kind of do need some sort of therapy with that.
Right. Right.
And so once you do that, then that helps the clinician figure out, okay, here's what we actually have to do to keep you on a long term, without your headache and so forth.
Right. Right. All right. Dr.
Chime
Williams,
in a little bit.
go ahead.
Migraines actually been described as the great stealer of time. What does that mean? It means it just so debilitating to a point where it causes you to lose function and loss of time in school or at work. And according to the AMA, the American Medical Association, there's no true reason, a cause for migraines, but it's been shown to be a hyper. One of the hypotheses is that it's been shown to be a hypersensitivity of the nerves, especially the neurological nerves, especially to the brain, all over to environment, even the food, and internal changes in the individual. Nevertheless, one of the great misconception of misnomer is, I'll break into this way: migraines and tension headaches. Some people have tension headaches and they think it's migraine, but they're two different things. But how do you differentiate each? One, tension headaches are usually last a few hours, usually less than 4 hours, and it's tense, persistent or steady, where it can happen in the front, the back, on the neck usually, and sometimes people feel a knot on the back of the head, and usually also from stress, emotional disturbances, and but migraines then usually one-sided, highly intense. It will last 4 to 72 hours, and of course, again, it's the emotional, stress and everything else that can result in it. So then, if you have to treat it, one of the first things I always tell some of my patients is you have to have a migraine diary. Find out what are the triggers to your migraine. Write them down. How many times do you get migraines? Write them down. And what are the things that would influence you helping or reducing the migraines? Because food, like caffeine or less sleep or too much sleep, MSG and all those things really do cause migraines. But you have to document those things down. So when you meet your doctor, you sit with them and say, these are my triggers. These are the things that make it worse. And you have to come up with a plan, a treatment plan for you that most likely will suit you, as compared to tension headaches, which you can treat with just, relaxation, stretching, or NSAIDs as well.
All right, thank you very much.
I can just mention a little bit about associations with migraine. While we think of migraine as predominantly associated with a very severe kind of headache, an understanding of the cause of the migraine and the relationships in medicine. So we've had several studies where we looked at people who suffer migraine, large groups who suffer migraine, and see if they have a tendency, a propensity for any other significant illness. And from my viewpoint, in terms of vascular and cardiac, we find a small but definite relationship between the occurrence of migraine and heart attacks, strokes, irregularities of the heart called atrial fibrillation. I want to caution you that these are not frequent associations, but we do find a statistical relationship between people who have migraine headaches and the tendency to have these other problems, so that we do not look at migraine lightly, but we pay great caution and attendance to it, and of course treat it as appropriate.
Right.
Right.
There are individuals,
Hey, Omar, if I can say
individuals
something,
who
you
are said
know,
to
as
have recurrent
Dr.
migraines.
Hold on, Doc. Dr. Patrick Anderson and then Dr. Aluya. Go ahead.
Yeah, I was just going to say something, both as a provider in women's health and someone who in the past has suffered from migraines. And with respect to the triggers and the potential cause. So while in general, we know that there is no one or two clear-cut causes, it's one of the great conundrums in medicine where it's multifactorial. So we talk about some of the environmental triggers, but sometimes it's not the incident itself, but what results as a result, not to be redundant, the result of the trigger. So for example, you know, when you even, the role of creating a diary of some of those triggers, and Dr. Aluya mentioned caffeine, we know that some of those triggers cause vasoconstriction, right? But we also know that caffeine
Vasoconstriction.
Right, helps with
define what
relaxation of the blood vessels and increased blood flow. And when you look at the description of some of the triggers, so for example, there's an ocular trigger, right? What happens to the retina and the hypersensitivity of the retina to the light. When you look at what happens to the brainstem, when you have some of these triggers that cause vasoconstriction that leads to dizziness and nausea and vomiting, these are often symptoms that centered around the brainstem. When you talk about muscle tension, right? When we talk about tension headaches as relates to hypertension and some other reasons for tension headaches, some of these hypersensitivity causes muscle constriction and ultimately increased muscle tension and ultimately venous constriction. So it's an interesting dilemma that's broad-based, and I think there are direct causes and indirect causes that lead to physiologic changes that ultimately leads to some of the triggers that actually cause headaches. Now, I can tell you from personal experience, I've gone from using acetaminophen with caffeine to hypnosis. I mean, I used to have my regular sessions with Dr. Johnson when I was a medical student. So it's a matter of creating a diary, knowing what trigger, recognizing the aura, and some of these triggers are often silent, right? So for example, we talk about fatigue and lack of sleep. For me, the worst thing is lack of sleep. But I can tell you, if I sleep too late, I get a headache. And how do I separate the two? It's difficult. So documentation, a diary, recognizing your pattern probably is the best treatment that some people can use to help themselves.
Excellent, excellent. All righty. Dr. Aluya, do you want to sum that up? Because we have quite a few questions coming up.
Right. So in the United States, about 28 million people suffer from migraines. But then the question is this: often enough, those who suffer from intense chronic migraine, those who are described as having chronic migraine, what does that mean? There are about 2.3 million people 3.3 actually million people in the country. And what does that mean? It means if you have up to 8 episodes of migraine days, minimum 4 hours and above in a month, you consider as having chronic migraines. Or you have 15 episodes of headaches or migraines, of which those headache periods are 4 hours or more, you're considered having chronic migraines. So those are definitions, so that if you come into any of those categories, then you need to see your doctor and find the best way to help treat it.
Excellent, excellent. Okay, we're going to go to the second question here, and it seems as though we're doing things around the brain. Here, let's check this out. Once again, could you discuss if there is a test that predicts if one is heading towards Alzheimer's disease? Are there early predictive symptoms of this disease? All righty, can someone help us out with Alzheimer's? All righty, some of the internal medicine or?
Well, I mean,
we don't have a neurologist on the go, but I know that we do see it in the office.
Well, Alzheimer's disease is unfortunately, a chronic debilitating disease, and it's often progressive, and the point where once it starts, there's hardly any process to stop it, but you may slow it down with activities or with certain medications. Ideally, usually it does happen in older age group, and often enough, we don't know the typical, the multifactorial issues that can predispose individuals to Alzheimer's. There's a percentage of individuals where it runs in the family, where if grandpa or grandma or father has Alzheimer's, you have a propensity as well to developing Alzheimer's. If you have a history of an infection, that affects the brain at one point or the other, it may, down the road, may affect increase your risk of having Alzheimer's or trauma as well. Also, metabolic diseases. There's a huge correlation now with diabetes and Alzheimer's, and then they begin to actually talk about, so-calledly the use of statins with the use of early onset of memory loss and disease progression. So it's without going too technical, it's affectations in the tissues of the brain called the neurons, where the neurons, ideally, if you take it like a wire, the casings on the wire begins to degenerate. Right. As they degenerate, you begin to have punch holes in those casings, and the information that transfers through begins to depreciate. You have byproducts, neurofibrillary tangles, they call them, and other things that attach to those things that make it degenerate faster than usual. So the best way usually to identify it is with MRI, when you take a look and see those changes and brain loss that take place. Now, I've had some people where on early cases you have 50-something-year-olds who've developed Alzheimer's, but then we don't really know, but then there's a strong family history or some assault sometime early in life. So I'll leave it there, and then probably others will chime in and we'll take it on from there as well.
All right.
Nelson, you can't get away. I just in terms of the bodily function and physiologic processes, are there conditions where substances gets deposited in tissues, such as amyloid and myelomatous diseases that present with symptoms of Alzheimer's early on?
Yes, if you know about myelomas or amyloids, there are two types, the AA and the AL type. And the AL usually the ones with, the disease itself, and then the chronic one out of either cancer or diabetes or any other chronic medical disease, or even chronic kidney disease, or those one dialysis. Those things can break down, and as they pass through the brain, they begin to attach to the tissue of the brain, especially the fatty aspect of the brain. Remember, there's a whole lot of fatty components, myelins and neuromyelins and sphingomyelinoceles and all those things, those technical terms that make up the tissue of the nerves of the brain. So those gets attached to them and begins to decrease the ability to transfer electrical impulses or messages along the brain. So yes, those things do happen.
Yeah, excellent.
From my experience, what I've seen in most of the patients, one of the first signs is they are very repetitive in terms of, if you have a discussion with a patient, say in 10 minutes, they will go to the same subject 3 or 4 times without even realizing what happens. And from then on, they may progress to other things where they become disoriented, they leave their house and all that stuff. But to me, the earliest sign that I've noticed is the pattern of going back and forth to the same subject in a 10-minute period. So if you can observe your family members carefully, you may be able to do something about it.
Right.
But just going back to the question, though, the question was, is there a test that can predict? And
well, In all sincerity, no, there's no test. There's no test to predict, but if there's a strong family history, yes, then you begin to start to pay attention and reduce those risks those factors that put you more at risk for them. So that even if for instance, I'll give you an example, if it happens at age 70 in your father or mother, then you can increase the age upon which you may develop it. Maybe you also develop at age 80. And how do you do that? We've shown that exercise is huge, huge in reducing the risk of Alzheimer's. Because again, what it does is actually opens up the blood vessels and the blood vessels go, and all those materials that help your brain to repair itself will get there as well. So as the good materials go in, bad materials come off. So that's how exercise happens. And even in the heart, that's why exercising really helps. Even with those with cancer, exercise really does help as well. Now, another thing that's been shown to actually help, they say help, but it may be mask, is for those who read a lot. And that's why they tend to tell elderly people you do word puzzles. Because we found that those who do those word puzzles and do those things, the appearance of Alzheimer's tend to be less. Why? There's what they call confabulation, because instead of saying, oh, it is very important, they may forget the word it is very important. They may say it's imperative. You understand? You're like, oh, grandma is really smart. No, it's my grandma forgot the word is very important. She just uses another word for it. So that's why it's important to read.
So Nelson, if I should throw a log on the fire, does it really matter if she says imperative or important, right? I always think that, we talk about exercise, but, when we say exercise, we think of physical exercise, right? But really the exercise you're talking about, or an important aspect, is activities that improve your cognitive ability, right? And it's kind of like knowing multiple paths from home to work, right? If there's a traffic jam, you still get to work. It might be a little late, but you get there nonetheless, right? So word puzzles, read a lot, doing these mathematical exercises are known to help. But one of the things we should not overlook is that sometimes when we see these subtle changes in what's considered normal behavioral pattern for people who are close to us, is sometimes just to make sure that, one, there is not underlying vascular disease, like as in, is this a subtle form of a transient ischemic attack or a quote unquote mini stroke that over time will accumulate and then eventually manifest themselves into symptoms or features of Alzheimer's. And then the other question I have for you is, we see, even though we're not here to advertise products, but we see these brain support supplements being advertised, Prevagen and those other things. I mean, are there data to support the use of these things?
Well, I think, what's this product from? I think it's from one of these deep sea products, right? I've forgotten the name now. Has been shown to really does help. I guess probably what they do with like a lot of multivitamins, they act as anti-metabolites. So they're anti-metabolites that are good for the heart, they're good for the knees, they're good for other tissues. So they're also very good for the nerves. So they go onto those nerves, help reduce those things that attach to them, reduce the risk of those things attaching to them. And that's basically what they really do. We've had some medications like, not to call names now, but Namenda and Aricept and all that, that have been shown to help reduce the progression of the disease. Now, the essence is this, and I must say this, the big word is dementia. There's a difference between dementia and Alzheimer's. Alzheimer's is one of the dementias that they are. They are Lewy body dementia, vascular dementia, and all that. So we need to understand those ones as compared to an entity of a disease called Alzheimer's, which is a diagnosis by itself. So Alzheimer's is a big, broad name for the whole thing. Now, the onset of Alzheimer's, when it starts, some people says, from onset to severe cases, life tends to be 8 years or less. So these are the times when you identify, get close to your family, help them out as much as possible, show them love, care and concerns, it really does help them. And post things that will help them remember things as well, because remote memories are there, but new memories, finding time to create new memories, that's what the problem is.
Right. All right. Thank you. Thank you very much. I must acknowledge Dr. James Lee. Thank you for joining, man. I know that you said you would be a little late. Could you introduce yourself, please?
Sure. Thank you, Omar. Good to see everybody. Dr. James Lee Jr., board certified orthopedic surgeon. Glad to be here.
All righty. I like that. I like that sweater, bro.
Yeah, I'm trying to flex a little bit, try to show a little bit more here.
All righty. Sounds good. Sounds good. All right. I'm going to go to the next question. This is a little long in the tooth, but I'm going to summarize. It's about BMP. So Dr. Atherley will help us out. And it states that it's a protein that we can evaluate the function of the heart. Is primarily used to diagnose and evaluate, obviously, heart failure. What they state is that, and he gives us information that less than 100 milliliters is considered good, and over 400 milliliters is considered very bad. He states that his is 345. I am in my late 60s, he says. How concerned should I be? And how can I bring this number down? So Dr. Atherley, can you help us out a little bit there?
BNP is, let's go to an understanding of what BNP is. It is a protein which is secreted from within the heart in response to certain phenomena. If the heart muscle is stretched or is subjected to increased pressure, some of these are signs of heart failure, then the heart may respond by producing an increased amount of the BNP. BNP may be broken down later on, but the BNP is merely a tool to help us in A, the diagnosis of congestive heart failure. I will tell you what congestive heart failure is, and B, in looking at the prognosis or the judging how bad it is and the future of this, and in helping us manage and treat the patients. So it's a useful tool, but it's merely a tool. I still think the most important aspects of the diagnosis rely on physical findings, the things the doctor sees when he examines you, and upon some of your other symptoms. So the BNP is an asset merely to help him in that diagnosis and in your treatment for congestive heart failure. For those who are not familiar with the term congestive heart failure, the heart is basically a muscular pump whose primary job is to push blood throughout the body. The blood comes back to the heart, it is oxygenated in the lungs, goes via the pulmonary arteries into the heart, the left side of the heart, and then this blood which is purified is pushed throughout the body again. So essentially it's a muscular pump. And heart failure in its most fundamental form suggests that the heart is failing to do its job. The heart may be weakened. There are a variety of causes of so-called heart failure. Now we're looking at heart failure even when the heart isn't weakened, just to complicate things. The heart in its filling phase may be stiffened, and that may also give rise to heart failure. So congestive heart failure is a term to suggest that the heart is not doing its job properly in pumping oxygenated blood and nutrients throughout the body. But the BNP is one of those tests that we can use along with our other clinical or physical evaluations to determine if this truly is so, because there are many other circumstances in which patients may have similar symptoms, similar findings, and we may not be sure if it is congestive heart failure. So one of the big differentiations is, of course, in Dr. Bay's field, pulmonary diseases, presenting with shortness of breath, fatigue, et cetera, and the question as to whether it truly is reflective of the lungs, other areas, or the heart. Well, here's where the BNP helps. The BNP elevation tends to suggest more strongly heart failure, weakness of the heart muscle, and therefore it allows us to go in that direction and treat the patients more appropriately. So it's merely a tool to be used in association with all of the other parameters we have for determining the function of the heart.
Yeah, I agree, Dr. Atherley. A lot of times we get patients to come to the hospital and basically they're short of breath and complaining of shortness of breath. And BNP helps a lot because it distinguishes whether it's pulmonary, a lung problem, or a heart problem. A lot of times I explain to the patients that the heart is a muscle and the blood has to go from chamber to chamber to chamber, but from going from the right side of the heart to the left side of the heart, it has to go through the lung. And if the left side of the heart, which is the muscle part of the heart, is not pushing the blood out into the body efficiently, what I tell them is that it's sort of the fluid part of the blood kind of backs up on the lungs, and the lungs get nice and soggy. And that's what happens with congestive heart failure. The fluid part of the lung fluid part of the blood gets into the lung tissue and makes it soggy, such that it makes it very difficult to get oxygen to the blood, and you feel short of breath. Yeah, hopefully I didn't get too technical there. But the thing of it is that you're so right. BMP helps us a lot. There's another question that came in for Dr. Lee. What is tendonitis, and how does it? How can we treat it? Mm-hmm.
That's a good question. So itis, means inflammation. So it just means inflammation of a tendon. In its most basic form, a tendon is the attachment between the muscle and the bone. So one that comes to mind is your Achilles tendon. So you take your calf muscle, and the tendon portion is the thick white portion made of collagen that attaches to your heel bone, or if you want the technical term, the calcaneus. Itis, as I stated, is inflammation, and typically it's treated with a few things. The most basic, rest, they call RICE, rest, ice, elevation, compression, and also you can use medication such as an anti-inflammatory ranging from Tylenol, Motrin, and in some forms we'll also do physical therapy where we allow basic stretching exercises, cold compress, and even sometimes heat to bring blood flow to the area. But in the athletic population, you might see overuse type of situation, such as tennis elbow. That is where the tendon in the elbow that extends the wrist over the elbow is inflamed, and they call it tennis elbow. It's oversimplified, but that's from people just hitting back and forth. In my practice, I see mail sorters, people who work in the post office, and they sort mail all day, and they'll come in and say, oh, my elbow hurts. And oftentimes you touch the area and say, ouch. Well, that's an inflammation where the tendon is, and that causes pain. Oftentimes it's treated with non-surgically, and a lot of time it's rest and what we call activity modification, essentially damage control. Stop the insult to that area and do some corrective activities like physical therapy and sometimes medication.
Excellent, excellent. All righty. There's another question that's here. It says, I would like to know how important it is to have a schedule set up for eating routine, eating routine when you are dealing with diabetes type 2. All right, so we know that with eating or type 2 diabetes, basically, you would want to, if possible, eat the right thing. Obviously, you want to stay away from carbohydrates and you want to decrease your sugars, but also a routine would be good. The number one thing is don't miss your meal, because the next meal usually is larger than you want it to be because you're hungry. Maybe someone else can kind of chime in on this one for me. Dr. Fredericks, I know this deals with.
I totally agree with you. I totally agree with you. You have to have some kind of routine. What tends to happen is your sugar levels start to elevate when you're eating things that are high in carbs that aren't refined, because the refinement takes out the fiber from the carbs, okay? And the fiber sort of keeps those levels elevated and constant. When you don't have fiber, those levels go up and down, and you start to become more and more insulin resistant, and that becomes a problem. And so if you're eating routinely, you want to make sure you're eating things that are going to have high fiber and you're eating consistently. And you don't want to end up getting, like Dr. Bay stated, you don't want to end up being hungry and where you're taking a great volume of food, and that could lead to more problems.
Mm-hmm. Yes, yes. Any other comments on this one? Because diabetes is something that is rampant in our community, and I feel that it has so many secondary effects that if we can keep it under control, then we would control so many other diseases. The eyes would be better, the kidneys would be better, the heart would be better. So many things would improve if we could improve diabetes. Anyone else want to chime on this?
Well, I would say, I'm the orthopedist, but I encounter many patients with diabetes in my practice. And if we are preparing to do an elective procedure, such as a knee replacement or maybe a shoulder surgery, oftentimes we'll order blood studies, and we'll look at the hemoglobin A1C, which is a 3-month measure of how well that sugar has been controlled. And, you know, we're looking for, you know, correct me if I'm wrong, 7 or below, maybe the six range, you're pre-diabetic. If you're 8, 9, 10, 11, it tells us that the sugars have not been regulated. So then exactly, so too high. And then if your diet and how you eat and your sugars are going up and down and you have insulin resistance, it's going to show up in that 3-month test and say, listen, that basically tells us that you haven't regulated your diet and the sugars are out of control.
Right. And it reflects on healing as well, right?
That's right. Exactly right. We see that over hemoglobin A1C about 8, we start to see more complications with wound healing, especially after total joint replacements.
Okay. Okay. All right.
Well, the only thing I'll add to that is we must recognize, especially those in the Black and Brown community, that diabetes has become, I mean, in 2016, it was actually declared an epidemic by the WHO and CDC. So it's a disease that has unequivocally affected Black and Brown people more than anything else. And you know, there've been some genetic predispositions and explanations for that. That diabetes is new to the Black gene, I must say, but it's something, if I say this, anybody who's watching or listening, please, when you go to your doctor, find out what your diabetes status is, meaning A1C. It should be part of your routine when you see your doctor. So if you're pre-diabetic, meaning less than 5.7, then you need to know. And if you're obese, then take steps to, cut back down, cut the food. A lot of the time it's the soda and all those high carbs food that we eat, and then increase your activity. If you're pre-diabetic, then that's 5.7 to about 6 without symptoms. Then you take those steps to do that. If you think you can't, seek some medications that help you reduce the risk. And if you're diabetic, you have to follow up what your A1C is within 3 months every time. And then not just that, because diabetes is the #1 cause of kidney failure in the world. And if you have blood pressure together, that's a double whammy. So you need to control those two, and make sure that they're both under control. And check your urine as well. Ask your doctor to check your urine for protein or microalbumin, because before the kidney fails, they begin to excrete those chemicals.
And as we alluded earlier, if the sugar is not controlled, it ends up being what we call type 3 diabetes, where you have dementia and problems like that, Alzheimer's.
Right.
It's important to recognize the diffuse nature. The diffuse nature of involvement of diabetes. Don't just think of one organ system, but think of the entire body. From my viewpoint, for example, diabetes is very, very important in terms of the potential for heart disease. Heart attacks occur more frequently in diabetics. They may present a little differently, more difficult to diagnose diabetics who have heart attacks because they may not give the typical symptoms. Diabetes can worsen heart failure. We talked about heart failure a little earlier. Can even predispose to irregular heartbeats. So diabetes can have multiple manifestations in affecting the heart, in worsening established heart disease, in making heart disease occur earlier in patients. Patients who have heart surgery may make the healing a little more difficult. Diabetes is very, very diffuse, very significant, and certainly plays a major role in heart disease as well as stroke.
Yeah,
vascular surgery as well.
Dr. Stratford, as an oral surgeon, being an oral surgeon, tell us how does it affect the teeth at all? And once your teeth are not, well, the mouth is the gateway to your body, as far as I'm concerned. Right. How does diabetes play as far as your specialty is concerned?
Well, I think we spoke to that once before, which actually becomes a real serious problem, because most of the time when someone has bad teeth, they tend to eat softer foods, which are high in carbohydrates, high in salt, because they're processed foods, and they don't tend to have a very consistent diet, something that actually is sustainable. And so what you're finding is that when you have an A1C that's at 8 or suboptimal levels, what you find is the healing is totally compromised. But secondly, we also know that diabetes affects the terminal branches, and so the teeth end up being one of the terminal branches with the artery, and so they lose their teeth. So we see these things coming forward, so there's no sense in me even doing a complex surgical procedure when I know that the healing is going to be uneventful. It's not going to work. So you start to counsel that patient on how they're eating and why are you not eating well. And you'll find most adults that are missing 6 to 8 teeth are not eating the foods that they need to eat because they can't. They can't bite down on solid foods. They can't eat the vegetables that they need to eat. And so their food becomes soft. They eat more pies, they eat more cakes, they eat more of pastas and things like that because it's things that they can actually chew. If we can get them back to a point where they can actually begin to eat their food and chew their food effectively, it starts to diminish gastric problems, diabetics, all the things that happen as a result of just poor eating habits. So we spend that time with the patients that we're talking about that want elective procedures and saying, oh, I want these implants, I want to get my teeth back. I just counsel them that you didn't get here overnight. So you can't get cured overnight because all you're going to do is create a bigger problem further down the road. So let's address the problem. Why aren't you eating right? Well, you don't have teeth. What are the problems? How did you get here? Well, you didn't get here from brushing your teeth or having good hygiene. So if I put these brand new implants in your mouth and they're expensive, they're not going to heal themselves. You have to begin to do the things that heavy lifting, which is a disciplined life. So I asked, do you floss? No, I don't floss. And I said, well, if you don't floss, there's 4 sides to your teeth. And so you're only brushing 2, the front and the back. What about the sides of your teeth? Well, that's where periodontal disease starts. That's where all the bacteria that leads to cardiac issues. And in the 2019 study, they also said it's one of the precursors that they found in 53 deceased individuals that were significant for Alzheimer's. So again, we're talking about some things that we just don't do. A disciplined life would lead to a whole lot of less problems for each of us. Because if you're eating right, chances of you having high blood pressure are diminished, unless it's something that you can't stop. If you're eating right, chances of you having diabetes is diminished. If you're eating right, chances of you having GI issues are diminished because you're chewing food. Most adult women have just 12 teeth, 6 on the top, 6 on the bottom, right in the front where they smile. So how are you chewing? You can't chew food from teeth that are made to bite into food. So all you're doing is mashing food with your tongue and swallowing it whole. Well, we have GI guys here, you know what happens. You can't do that for very long without something happening. If you're eating softer foods as you get older because you can't actually chew food, we find adults in the 6th and 7th decade of life that are eating, what is that thing? Cheerios, honey nut Cheerios for breakfast and lunch, waiting till it gets soggy so they can eat. Well, what you're doing is the teeth that you have left, once the milk gets a hold of those teeth are going to decay faster than anything else. So what are you doing? So it's a conversation. And what we're doing here, Dr. Brea, and all of you guys, I commend you, because it is a conversation that needs to be had. It's a tough conversation sometimes, but as I say, to some people, only floss the teeth you want to keep. It starts a laugh, but it's reality, right? Because if you don't do it, I mean, I have the method of treating it, which is just to take them out. But then what, right? So,
take them out, chompers.
Yeah. So I mean, and even in doing any surgery, especially bone surgery, I mean, there's no healing that's going to happen if your diabetes is out of control. I'm not going to put implants in you. You have to go somewhere else because it's not going to work. So rather than send you somewhere else without some reasonable way of getting back to a sense of normalcy, and that's where all of you guys come into play. It's that conversation that sometimes I ask patients, do you deserve better? Because they want to run in and they want to run out. And I said, listen, you're doc, last doctor I went to, he only spent 5 minutes. I said, sometimes, God bless you, sometimes the system, the healthcare system prevents us from being good doctors. But what you're doing right here says that we're trying to be better doctors than the system has predicted we would be. Because I said to some of them that come by, well, do you take this, my HMO, or do you take this, you take that? And I say, no, I can't. I can't survive on a $5 office visit. But
Right.
if you deserve better, let's sit and talk.
Right.
That helps that patient.
Mhm.
I'm going to give you just a few minutes and just say, listen, this is what you need.
Right.
And I know the system is against you, but listen, we can make this happen if you just try these things.
Right, right. And it's so important. It's so important. All what you said is so important. That's so great.
I'll be brief.
I'm sorry. Go ahead, Dr. Court.
I have a comment.
Yeah, Dr. Court.
Yes. My comment is that I think the caller wanted to know what can be done, because in my practice, I find that the instances where the patient's blood sugars are not controlled very well is because of what they eat.
Mm-hmm.
And sometimes we neglect to bring in a dietitian to help us, because they can tailor, work with a meal plan. So many calories for lunch, so many for breakfast, so many for dinner. And by doing that, I've seen marked improvement in terms of the patient's blood sugar control. So please don't ever forget the role of the dietitian.
Right. Excellent. Excellent. All right. I just want to let you know that Dr. Jordan Garrison has joined us. Dr. Garrison, can you introduce yourself, please?
Good afternoon. My name is Jordan Garrison. I'm a general surgeon. I have specialties in bariatric as well as vein surgery. Currently, I am employed with Metro Vein Centers, and we do all kinds of diseases associated with venous disorders. It's a pleasure to be here.
All right, thank you. Thank you for joining us, Doc. I know it's these busy Saturdays, and it's always good to see you and have you join the team. The next question is, right. Actually, yeah, one more question, and then we're going to have halftime. What is the reason behind holding lobetalol from a hypertensive? And this is Dr. Patrick Anderson. Maybe you can help us out with this. My blood pressure is 180 over 30. I'm a G1 and I guess that gravida 1 and well, G1 PO, you'll understand that. I'm a woman that's 38 weeks gestation, though she has no headaches, visual disturbances, chest pain, or abdominal pain. So she's specifically talking about this particular hypertensive medication. Maybe you can help us out with this, or Dr. Atherley, you may be able to play with this as well. Can you help us out?
Omar, I'm not exactly sure, as this is not truly my area of practice. What I do suspect, and I will have to get the information from this individual and get back to them once I get information from one of our maternal fetal medicine doctor. But it may have to do with dramatically slowing down the patient's heartbeat and how it might affect the placental blood flow. A gravida 1 para 0 suggests that this is a woman who is her first pregnancy and she has not had delivered a full-term baby, and she's close to term. She's 38 weeks. 38 to 39 weeks to 40 weeks is considered full term. I suspect that's the reason, but I could via email get the true reason and get the right answer from the right people for her.
Right. Okay.
Sorry, if I may ask, Dr. Anderson,
yes.
One of the biggest issues that concerns us, especially people of color, is blood pressure. Women, blood pressure, and pregnancy. We studies have shown that Black women, especially who are getting pregnant for the first time, have a high risk of high blood pressure and all that, even when they have the baby. What's your take on that, and what would you advise them?
So what we do know is that preeclampsia or hypertensive disease of preeclampsia or eclampsia, hypertensive disease of pregnancy, is a predictor of hypertensive disease in women as they get older. And indeed, whether through genetics or lifestyle reasons, preeclampsia and eclampsia tend to be more common in women of color. And it probably is one of the leading cause of some of the conversation surrounding discrepant outcomes in maternal and fetal and neonatal medicine. But similar to diabetes, young women who develop gestational diabetics and women who develop hypertensive disorders in pregnancy is at risk for developing said chronic disorders as they get older.
My take on the labetalol question.
Hold on. Dr. Atherley first, and then we're going to have Dr. Garrison.
Yeah, my take on the labetalol question. I'm not sure why specifically that was held. Labetalol, there have been many studies involving beta blockers. Labetalol is one of a family of beta blockers, very useful in some certain circumstances in hypertension. However, there was a question of whether it would have an effect on the fetus, but it has been shown that beta blockers do not cause any increase in stillbirths. They may cause low birth weight. There may be associated with low birth weight babies. However, I think that the concern here may be the potential for slowing the heart rate in the infant, and early after birth having a slow heart rate. So what we call fetal bradycardia may be one of the concerns with the mother taking beta blockers, of which labetalol is one of the members of that family. So I would just exhibit caution. I'm not sure if the current status among the OBGYN experts is that it should not be given at all. That's another story.
Wow. Dr. Garrison?
I'd like to just direct this question to a real deal issue as far as compliance, beta blockers and labetalol. So this is Dr. Atherley, Dr. Court, and Dr. Aluya. What is the relationship to labetalol, beta blockers, and libido? And is it the same in men as it is in women? Okay, real deal question. Okay.
Well, let's answer that. Let's answer that question.
I'll take a quick swipe at something quickly, and that's because with reference to what with the pregnant woman, I've often, even as a resident and as an attending and as assistant professor, we often get consults to women who are pregnant, who just had the baby. Now, pre-pregnancy, a few women who have high blood pressure will be put on certain medications, like the ACE inhibitors, the angiotensin, converting enzymes inhibitors. Those are the ones that ends with a pril, the captopril, enalapril, all of those. They've also been some who've been put on calcium channel blockers, and of course the beta blocker, which we just talked about. However, currently, and then there's what they call the alpha methyl dopa. These are old, kind of blood pressure pill and other ones. But the current recommendation is alpha beta blocker, which is labetalol or carvedilol. But the labetalol has been the one that's been preferred as a first line of treatment for women who are pregnant with high blood pressure. Now, if they're not controlled, then you add other things. One of the meds to stay away from are the ACE inhibitors, meaning the reals, the captopril, the enalapril, because it's been shown to reduce the blood flow of the fetus kidney. So if you put them on that, the blood flow to the kidney is compromised, and the babies would have renal problems and subsequent other issues. So you stay away from that, and that's why when they're pregnant, they take them off the ACE inhibitors and put them on beta blocker and all the stuff like that. Now, coming back to Dr. Garrison's question, I hear that all the time. My patient are like, man, the mojo is not working as properly anymore. What could we do? Metoprolol is notorious for that. And we've had a lot of people complain, but it's not everybody. It's just like with the ACE inhibitors, some of them have the cough, some have the angioedema, which is the swelling of the lips and the tongue. But some people have libido problem with metoprolol, but not necessarily the alpha beta blocker like labetalol.
All righty.
But Omar, it goes back.
Dr. Court.
It goes back to what we know. We cannot guarantee that any antihypertensive medications would not cause, libido problems. You have to take it, and then you would see. we would always find one medication that would work, that would control the patient's blood pressure and not affect their libido.
Right, right.
Dr. Day, one of the beautiful things about this platform that we're using is, we get information in real time. And, while we're talking, I reach out to some of my experts in maternal fetal medicine and some of our practicing obstetrician. And some of the comment is that they really don't stop it during pregnancy. And they don't believe that there is an increased risk of fetal bradycardia. So for this particular situation, I am not sure why they stopped the labetalol. Is it because the individual is not responding to it and there's a need to try something else? I just reached out to a couple of our experts who said they really don't stop it. In fact, they use it quite a bit.
All righty. Now, another question. You know what I would like to get from this question, and then I kind of glossed over it the first time and looking at it.
Dr. Bay, sorry. One thing, if I may say something quickly. Now, if you're on the medication and the mojo is not working anymore, one of the things I always do, please check your testosterone level, because as we grow older, your testosterone level tends to fall. And we often don't recognize that, and it really does make a whole lot of difference. But then if there's nothing else, sometimes there are issues with the pituitary gland, which is the small gland that controls all the hormones in the body. But those are things, steps that you need to take.
Right.
So you
Another
have
comment, which the vascular doctor may help us with. In order to have the mojo working very well, you have to have blood flow.
I think that's one of the points I was going to make, actually, that the question, we often blame the medications in terms of causing this, and beta blockers, again, the labetalol, the metoprolol, these are some of the most important ones, and we try to change these when patients present with libido problems. But I always remind my patients that, as Dr. Cort was pointing out, it's a question of blood flow. Many of these patients who have severe hypertension and have coexisting coronary artery blockages, that is blockages of other arteries on the surface of the heart, arteries elsewhere, may have pretty widespread disease of partial blockage of arteries in many areas in the body. And blockage of arteries that supply blood to the penis may be one of these. And so patients have to remember that it may not only be the medication, maybe an intrinsic problem with the artery disease that they're having. So it's fine to stop the medication, change the medication, try to find other medications that may not have the same supposed effect. But remember, it may be more than just the medication.
Right.
Dr. Aluya, you alluded to exogenous testosterone usage. Are you an advocate of that?
Yes, if you confirm that your testosterone level is low, yes, you can use it. I've given it, it depends on how low it is. Some are really, really low, every 2 weeks for maybe 2 to 3 months, and then we check the level again and make sure it's at level, and then can space it to every 4 months or every month or every 2 months or other like that. Because again, it increases the risk of, some have saying the risk of prostate cancer. So you got to be careful when you do that.
That's how we might get greater compliance with the vaccine if we give testosterone along with the vaccine.
Yeah, men will be lining up. Yeah. All righty. As I was stating, there was one aspect of this question, and Patrick, help us out with this. The patient's blood pressure is 180/30. All righty. And what there is something called, especially in our communities, high risk of pregnancy.
Right.
Can you just talk about this a little bit for us?
So with respect to this specific problem question, some of the antihypertensives that are safe to use in pregnancy, nifedipine, labetalol, methyl-dopa, and hydrochlorothiazide, those are known to be safe. Antihypertensive agents used in urgent blood pressure control in pregnancy, those also include labetalol, hydralazine, and nifedipine. So I'm not sure if in this particular circumstance there was an additional reason. Is this a person who is, for example, an asthmatic with a bradycardia, and there is no room to adjust, so the medication might have stopped or been switched? You know, sometimes
What I really wanted to get to was high-risk pregnancy.
Mhm.
Not particularly this question, but you know, we as African American, especially females, that a lot of times, you know, we get pregnant late, and that's you know, in our 40s maybe. That's high-risk pregnancy. Where do we come in that kind of category? Who would come under the category of high-risk pregnancy? That's basically what I'm asking.
Sometimes you can look at it globally as a set of risk factors. So we can include in that advanced maternal age, age greater than 40, obesity, patients with chronic illnesses such as collagen vascular illnesses, diabetes, hypertension. We know that that particular group of patients going into, whether it's a first pregnancy or repeat pregnancies, that pregnancy can be a high-risk pregnancy from both a physiologic and metabolic standpoint and from a genetic standpoint, right? So pregnancies later on, whether it's first time or not, should come with some pre-conceptual counseling. Unfortunately, not unfortunately, fortunately, in our system where we work, we have a very robust maternal fetal medicine service that includes people who are expert in metabolic diseases, hypertensive diseases, cardiac diseases. We're one of those systems that actually boasts delivering patients post-cardiac transplant. I'm sure Dr. Atherley is aware of some of those patients. And also we have the genetic counselors that speaks to risk of abnormal genetic developments in fetuses based on history and known genetic profiles. And this expands not just anatomic abnormalities, but also the risk of developing cancers going forward. And then you have the younger patients who have no known history of any chronic illnesses that develop some of these illnesses in their first pregnancies, like the hypertensive illnesses in pregnancies, like gestational diabetes. We know that these are the patients that we should get into a system of counseling and advanced primary care early on in their life, because these are the said patients who are still at risk for diabetes, hypertension, heart disease, and renal disease as they get older. And we know also that family history is important. So when you look at mom and dad with hypertension, strokes, and diabetes in some of these young, otherwise healthy patients, when they themselves become pregnant, develop some of these conditions, not just during pregnancy, but also as they get older.
All right, thank you. Excellent, Patrick. Excellent. I would like to take a break just right now. This is our halftime. A lot of participants has come in and did not catch who we are and our specialties. Right now, I would like to ask, and I'm going to go through each doctor as it's on my screen, to introduce themselves again. Dr. Dwayne Fredericks, please.
Good afternoon. I'm Dr. Dwayne Fredericks. I'm a bariatric surgeon, and I practice in South Orange. I'm now primarily doing medical management for weight because obesity becomes such a problem that sometimes surgery isn't the answer.
All right, thank you, thank you. Dr. Kevin Clark, please.
Hi, good afternoon. I'm a surgical oncologist. I work at Newark, Beth Israel.
All righty. Excellent, excellent. Dr. Trevor Atherley.
Good afternoon. I'm an interventional cardiologist, predominantly out of Beth Israel Hospital in Newark.
All righty. And Dr. Douglas Stratford, please. Dr. Stratford?
You're muted.
Sorry about that.
That's okay.
Yeah, oral surgery, specifically implant dentistry in all phases of it.
All righty, thank you. Thank you. Dr. James Court.
Court, East Orange. My specialty is internal medicine. I treat adults.
All right, thank you. Dr. Nelson Aluya.
Nelson Aluya, internal medicine pediatrics, Newark Beth Israel Medical Center, Newark, New Jersey.
Excellent, excellent. Dr. Patrick Anderson.
I am Dr. Anderson. I'm a GYN oncologist. Most of my work is out of Beth Israel Medical Center. I treat women with cancers of the reproductive system.
All righty. And Dr. James Lee.
Hi, Dr. James Lee Jr., board certified orthopedic surgeon, West Orange, New Jersey.
All righty. And Dr. Jordan Garrison. Jordan, your mic is muted.
Hi, Jordan Garrison. I'm board certified general bariatric and vascular surgeon specializing in venous disorders.
Okay, thank you. And as usual, beginning, I forgot to introduce myself. I'm Dr. Omar Bey, and I am a pulmonary critical care physician with a specialty in nutrition. All righty. So what I'd like to say is that we're here on web. You just have to go to OBHealthy every second Saturday at 1 o'clock. And I'd like for you to let friends and family know, okay? The most important thing that I can say today is do not change any aspect of your medical care until you consult your physician. Each and every one of us are different. Each and every one of us will respond to medications differently. Only your physician knows exactly the best route to treat you for your medical problems. All right. Let's begin and let's move on. There is a question for Dr. Garrison. My legs are very painful when I walk. What is the problem? What do you think the problem is? And how can I decrease the pain in my legs as I walk? Also, the question asked something about, do you think that they have a lot of varicose veins? And do you think that is the reason that they're having the pain?
Okay. A quick synopsis, you have basically two systems in the legs. One is the arterial system, which delivers blood with oxygen in it, and the venous system, which removes the unoxygenated blood. Pain in the legs, especially when you're walking, sounds like a condition called claudication. And what that is basically you do an effort and there's not enough blood flow to sustain that effort, and the result is pain. The same thing happens in the heart, as Dr. Athley can tell us, and that is called a myocardial infarction or a heart attack when that happens. Typically, veins bring the blood out of the legs, and the symptoms that you'll have when the blood goes backwards, when the vein is not competent, you'll have swelling, you'll have feelings of heaviness, fatigue, tiredness, cramping, itching, burning, redness. And then when you lay down at night, a frequent cause of restless leg syndrome is undiagnosed venous disorders. So if this was a venous problem as well as an arterial problem, then what would be necessary is an ultrasound to evaluate both the arteries and the veins. And that would delineate which one it is. And based upon what the findings are, would be the type of treatment that would be necessary. In dealing with venous disorders, when the blood is flowing backwards from incompetent veins, it gives rise to the physical signs or the ropey varicose veins or spider veins in your legs. Again, these all can be treated. Now they're being treated both arterial as well as venous with non-invasive means. And again, what the initial step in diagnosis would be a venous or an arterial ultrasound, and then a treatment plan individualized to the symptoms or the findings of that ultrasound would be necessary.
Mm-hmm, mm-hmm. Do you find a lot of patients coming to you? Because I know as females get older, and males as well, I have actually patients that have varicosities, and you know, or the veins, you can see the veins in their legs. Basically, do you find people coming to take care of those just because of a cosmetic type of treatment?
There's a breakdown usually. Women come in because of the symptoms of tiredness, fatigue, and pain from standing long periods of time, and then the cosmetic, the venous, the spider veins, and the varicose vein. Men typically come in because they have big, ropey varicose veins that look like worms underneath the skin. So basically, they come in for different reasons, but the underlying problems are the same in venous insufficiency, in which the blood is flowing backwards as opposed to going forwards.
Okay, all right, thank you. You know, there's a question that came in about losing weight. Dr. Fredericks, how much weight loss per month is healthy? And I hear if I lose weight too fast, it's not healthy. I mean, what are we talking about there? I mean, you know, how much weight is unhealthy to lose in a short period of time?
I think more than 4 to 5 pounds it becomes problematic unless you have some kind of surgical intervention. Using around 2 to 3 pounds is a good, steady, consistent weight loss. That's more achievable, easy to sustain. When you're trying to lose a lot of weight like that, it can be an aspect of that of you being dehydrated, and you may have lost a lot of fluids, and so that may not be as healthy as losing it more consistent and easy to control.
Right. What time period are you talking? Are you talking 2 or 3, 1 to 2 pounds within a week or a month, or what are we talking about?
A month, monthly, 1 to 2 pounds a month.
Mm-hmm. All right then. Now, another question
to that. Sorry, Dr. Frederick. Now, a lot of people go through bariatric surgery, which you do, and
Correct.
almost precipitously lose weight, and really fast at that matter too, which sometimes can be harmful. What would you tell them? What would you advise?
Well, for the type of surgery that they have, that's going to be different. Having a surgery like a lap band, where you lose 2 to 3 pounds a month, that's a good sustainable weight loss. They're able to sustain that. Having a procedure like a sleeve, you would lose 5 pounds a month. Having something like a gastric bypass, you could even lose even more weight. And it all depends on where you started out. If you're morbidly obese, significantly obese, and you have more weight to lose. But if you're a person like you that doesn't need to lose that much weight, that's a different scenario.
Yeah,
Can I just weigh in on that?
yeah, go ahead, Jordan.
You're talking about hazardous weight loss. Well, one of the
Correct.
things that a bariatric surgeon does is the patient is seen in follow-up on a regular basis. You have to think about the first month, because the surgery that was done, they cannot eat solid food. And also you're going to be limiting the amount of solid food that they get. So the first month they are going to have precipitous weight loss of 20 pounds, maybe 25 pounds. But the thing is, they're put on nutritional supplements. The fluids that they have should be 80 grams of protein per day. And that can be had in a liquid form. And that's why I think the weight loss is a multimodality thing. Yes, what we do as surgeons is very dramatic and very important, but without the support of the nutritionist, without the support of the primary care doctors like yourself, it's doomed for failure. So it has to be a multimodality approach to this weight loss problem, with the support of nutritionists, the support of the primary care doctor, the cardiologist to monitor those medications, because they might not need the medications that they're on for longer than 1 or 2 weeks. So the surgeon will monitor the surgeon, they'll monitor some of the nutritional intake, but you guys are the most important part after the surgery.
Right. And also, I just want to say that sometimes, and I understand with the sleeve, it's less, but there are vitamin deficiencies. And if patients post-surgery are finding that they're having, a decrease in sensitivity in their nerves or anything that you may think that would be associated with post-surgery, they should actually seek their doctor and stay in contact with the physician that did the surgery and their primary care doc. And you're so right, because I truly feel that the concept of losing weight is easy, but the actual losing weight is a difficult situation, and no one should lose weight alone. You should have, your family involved, your church involved, maybe weight loss groups involved. You must have others supporting you.
Yeah, I definitely agree with that. Support group is paramount. For a patient to lose weight and sustain that weight loss, multiple people have to be involved in that. Because what tends to happen is when you're lonely, when you're depressed, and you can get depressed from losing that weight. A lot of times people think that losing weight is the panacea, everything gets better. But they realize that after I've lost this weight, I still have these same problems, and they become depressed. They end up, and sometimes they have addictive personalities, and now they end up drinking. And that's a problem that becomes a whole different ballgame. So you have to have that support group in place, and you have to follow up with your doctor.
So Dr. Garrison and Dr. Fredericks, so that being said, how do you, or what modalities do you do in pre-surgical counseling for some of these patients? I know Dr. Clark and I are getting ready to do a very radical intervention of a patient, and we're going to do reconstruction. and, you know, is wanting to say, get rid of the cancer, lose the weight. This is what we're going to do, A, B, and C. And we make it sound so great because we do it all the time. But, you know, weight loss is one thing, but these are life-altering interventions. What counseling goes into getting these patients ready for such an intervention?
Sure. Everyone sees my nutritionist, but the main thing is everyone has to be psychologically evaluated. Paramount. Because a lot of times people have a false expectation of what they're actually having done. And so it's really important that they get cleared by my psychologist to determine whether they're a qualified person to have that weight loss surgery.
A lot of times, and I think you're giving a scenario that we're faced with as bariatric surgeons a lot, is the person comes in with life-threatening problems. And although, you know, the bariatric surgery is going to be helpful in their overall health, if you've got somebody that has a cancer that needs to be addressed, you got to go ahead and address that first. And then there are other things, like for instance, with Dr. Lee, we'll have patients that come in with chronic knee problems who need knee replacements. And it's sort of like, we got to get together and talk about that because they have to be able to exercise afterwards. But if their knees are bad, their joints are bad, then how are they going to be able to exercise? So again, it has to be a multimodality approach. It can't be, okay, I'm going to do the surgery and not think about anything else. You know, we have to weigh in. And that's something that, Dr. Lee, what do you think? Should they have their knee replacement first or the bariatric surgery? You know, what do you think?
So, you know, I think if they're having joint pain and, you know, we've done a full evaluation, which includes x-ray, a good physical exam. The x-ray shows bone-on-bone arthritis, and this individual has tried medication and injections, but they haven't tried weight loss. I would counsel them to try the weight loss first. Even with an arthritic knee, there's still a chance that their pain will improve. Mm-hmm. And, you know, I get this analogy a lot, you know, from my father. You know, you cannot have a Greyhound bus on Volkswagen tires. It's not going to work. So when somebody is overweight and they're really wearing out that joint, they're going to have issues. If you're able to say, all right, let's go from, you know, a Greyhound bus to a Honda, maybe that, you know, it'll work out a little bit better, but at least give yourself a chance. And as we discussed, and it's been mentioned before, I think Dr. Stratford used the term the heavy lifting. People don't want to change the lifestyle. They don't want to lose the weight. They say, "Oh, fix me, you know, I'll do this knee replacement." And we try to tell them, hey, that is a very small part of the equation. You're focusing and you know, they're fixated and they're perseverating on the knee when in fact they got to look at the big picture. And that's part of what, as a surgeon, we counsel people to say, hey, listen, that is not, you know, the answer. The answer is going to be change the lifestyle, come back. If your pain is better, great. Then, you know, then maybe the problem solved. If it is not, then fine. Your outcome will be better if you can manage with the weight and you're not out of breath because you're so heavy to try and recover from the knee replacement surgery.
You know, and I know we're beating up on Jordan.
Dr. Lee, a lot of times.
Hold on. Let Dr. Anderson and then Dr. Fredericks.
Okay. Yeah, so I know we're beating up on Jordan and Dwayne a bit, but, you know, I've been in a situation where, you know, I have actually was at the bedside with a bariatric surgeon. You know, obviously I was there to evaluate her for another reason. And the conversation was, you know, I will consider your surgery, but you have to lose 100 pounds. So how do we take someone who comes to you for active intervention and say, okay, you have to make some changes similar to what you asked me to help you to change before I can help you? I mean, are there programs to help patients actively lose weight prior to actually having the weight loss surgery?
That's Dr. Fredericks right there all over.
Mm-hmm. Yeah, a lot of times we use medical management to help a person lose a significant amount of weight. And then they have that knee surgery. I think it can, and if that knee surgery is successful, then they can go back and get a bariatric surgery to lose even more weight. But to get to that point of having that surgery, we can go do some medical management, have them lose a certain amount of weight, have them have their knee surgery, and then preserve their joint, because putting on 1 pound, 4 pounds of pressure on their knee, right? Right. And so if you just lose a certain amount of weight, they already start to have that decreased pressure on their joints.
Right. And I think it summed it up earlier, Patrick. You know, the thing of it is that that regimen of commitment, number one, from the patient, but number two, putting them in a program. And there are programs out there like Dr. Fredericks has in his office that will follow the patient very closely as far as helping them with weight loss, getting them the dietitian, making sure that it happens as far as what they're eating is appropriate for the weight loss, proper weight loss so they can move on. That program is so important. And I'm just glad that we have Dr. Fredericks in our area that we can refer to him so that we can take care of these patients, because some patients, even prior to the gastric surgery, they must lose weight in order to have the surgery. They are too heavy for the surgery. And that's happened quite often.
It's a safer surgery the more weight you can lose. If I can have a person with a certain amount of...
One more thing, and Dr. Salam is not on the call with us today, but Dr. Salam is the psychiatrist who has been with us. And there's the adage, no matter where you go, there you are. You bring you with you. Right. And a lot of these patients who are morbidly obese have deep-rooted psychological problems.
Yes.
And if those problems aren't addressed, we're setting ourselves up for failure. If failure, the surgery may be successful, but then we're going to have problems that they're going to, as Dr. Fredericks alluded to, we're going to have substitution. We're going to have substitution with drugs because we're taking their drug away by doing bariatric surgery. Food is the drug. So now there's substitution with alcohol and some other substances, or sex, or with other things. And so if these psychological issues aren't addressed, now they don't have to be cured, but they need to be addressed prior to surgery. Otherwise, we're just setting that patient up for failure.
All right, thank you very much. What a discussion. All righty, Dr. Clark, can you help me out with this one? Does large breasts increase the chance of getting breast cancer?
Yes and no. So
I like those yes and no answers. Go ahead.
Politician.
Well, so the more glandular tissue that you have, the more at risk tissue that is. So the breast is composed of a couple different types of tissue. So you have the fatty tissue and you have the glandular tissue. Just because you have big breasts doesn't mean you have a lot of glandular tissue. But what's a little bit more important is probably breast density. And that refers to how much glandular tissue you have. The more dense breasts women have, the more increased risk they have over time of developing breast cancer. So it's not as straightforward as just the size. It's really what's the composition of the breast.
Okay, excellent.
So
go ahead.
So, Kevin, I'm throwing you back under the bus. So you're implying that the size of the breast can create a diagnostic dilemma, right? With respect to density of the breast, the amount of breast tissue, and using the different diagnostic modalities that we have.
So size itself, size itself can pose a physical problem because some of the modalities that we have, for instance, mammogram, sometimes the breasts are too big to fit into the machine. So we're not able to see properly. And there are two areas that are of concern that we don't usually see. So very posterior, up along the chest wall is a typical area that's missed. And the inferior surface, or the very low part of the breast, is an area that's typically missed. So from a physical standpoint, if you can't get into the machine, that can limit it. But in and of itself, large breasts, as long as the machine is able to function properly, and when I say machine, I mean mammogram and ultrasound, and even breast MRI, then it doesn't really pose a problem. Now, dense breasts, on the other hand, which means that you have a lot of glandular tissue, now you can miss a very small cancer because that background now is very white, and cancer typically shows up as a white spot on these images. So if you have a background that's already very white and you want to pick up a small cancer, which also shows up as a white spot, then it becomes a little bit difficult.
Yeah, boy.
Yeah, I also think one important aspect of this, and I think guys like Kevin and myself are fortunate to work with some people in our breast center who are really good diagnosticians. So for example, you know, the mammary glands make milk, and, you know, milk has calcium in it. And sometimes on mammograms, you see these microcalcifications. And, you know, we know you can develop a cancer between mammograms. So we really need these experts who can look at the mammogram. And when they say do compression views, what does that mean? You know, some of these compression views actually cause layering of the tissue. And we know that if this is because of there's increased milk residuum in the breast causing these calcification, you know, they can see different things like layering. They can look at the characteristics of the different orientation of the calcification and give you a pretty good indication of whether this is more of an inflammatory type, a physiologic type, or a malignant type of a process. So, you know, to our horn, I think that the folks in the system that we work with are really very good at doing things like that. And they do it in such a way that they try to limit unnecessary intervention. And, you know, Kevin, I think it's on Tuesdays, they have this really robust breast tumor board where even some of the diagnostic dilemmas get presented with films and discussions and data that, you know, is really educational. So if some of us could really join some of those sessions, it would really be helpful.
All righty, excellent, excellent. I want to go to the next question. Are calcium supplements necessary? If so, how much and in what form? Does it prevent osteoporosis? Can someone help me out with osteoporosis and calcium?
I'll chime in.
Okay, go ahead.
So, sure. So, you know, osteoporosis essentially is a bone disease where the bone is like a sponge, and when you lose structure, you have more holes in it. It becomes weak, and it's a dynamic process. I like to look at it as, you know, as we're young, we have a bank full of calcium, and as we age, it diminishes for a number of reasons. The important thing is also to recognize with calcium, in order for it to get in your body, you need vitamin D to help the absorption in the gut. And so there's a certain amount of calcium you should take on a daily basis. And as, you know, women who start to enter that postmenopausal state, as they get older, they need to take calcium. The issue also is if you have a first-degree relative, mother, father, a mother or a first-degree relative who has osteoporosis, you're at risk for developing osteoporosis. On top of that, if somebody is concerned about bone disease, we'll also counsel them on exercise, you know, maintaining some form of exercise so that the bone metabolism is enhanced. As you walk, it actually stimulates bone formation. So I think there certainly is a need for daily calcium. Also keeping in mind that you need vitamin D to absorb it. Not every person should be on calcium. I'll certainly defer to some of the internists regarding some of the contraindications, but I think if it's something that's going to be on your routine patient, it is appropriate.
Mm-hmm.
Yeah, I think, you know, the whole process is a complex one. Dr. Lee pointed out patients getting into the postmenopausal phase of their life, where estrogen is important. Or lack of it is also important. It affects the heart, it affects the bones, because it does is an intricate part of calcium metabolism and bone uptake. So the combination of calcium, vitamin D, hormone replacement where it's safe and indicated, and weight-bearing exercise does help preserve the bony structure.
Excellent. Anyone else? All righty. And we'll go on to the next question. This is for Dr. Stratford. And I am a middle-aged woman and still have all 4 of my wisdom teeth. They all erupted years ago and don't seem to have any issues with respect to how they erupted. However, because I apparently am not being as effective as I would like keeping them clean, and they are developing cavities. My dentist has recommended I get them removed, but I have resisted for a variety of reasons. Is there a way to do more to keep my wisdom teeth and continue to continuing to deteriorate and impacting my other teeth, i.e. nearby molars? I know that was a long question, Dr. Stratford, but can you help us out? Is he, I think he's,
I don't think he can hear you.
oh, can you hear me, Dr. Stratford?
Now I can, but it's going in and out a little bit, so I missed the question.
All righty. Well, oh boy, that was a long one too. Well, basically what she said was that she has, her wisdom teeth came in and they came in fine and she still has them, but she's not cleaning appropriately. And what's happening, her dentist recommended that she get them out, but she's resisting. Is there anything she can do to, I'll read the last sentence. Is there any way to do more to keep my wisdom teeth from continuing to deteriorate and impacting my other teeth, i.e. my molars?
Yes, actually, the one thing you can do is you'll have to get some flossing aids or a water pick specifically. Then there is a surgical interventions that the periodontist can do, or even your dentist can do it, where you're just removing that supragingival tissue that surrounds the top of the tooth. It's the gum tissue that's a little higher than it should be. And so they remove it to a level where you can keep it clean. Because the only reason you're gonna have a problem with any of your teeth, especially in the back. Hello?
Yeah,
Can
we
you
can hear you.
Oh, I'm sorry. And so once you can keep it clean, then you don't have a problem. So it's just a matter of removing that gum tissue in that area. It's called an operculectomy, but all you're doing is essentially, you can use a diamond, you can use a scalpel blade, or even electrosurge, and just gently remove about 2 or 3 millimeters of soft tissue from around that tooth, which allows it to stay clean. And so then you can actually floss it. And if you can't floss it because of whatever reason, then get a water pick. Now there are a lot of water picks are good, but the goal with the water pick is to make sure you use it. And if you use it, it works almost as well as dental floss. But you gotta floss it because that's the only reason you'll get a cavity, or it'll affect the tooth adjacent to it. So that way you can keep it.
All righty, excellent. There's another question that came in. It states that, and I'm going to direct this to Dr. Athley. It's kind of a vague question. There are heart meds that allegedly contribute to memory issues. What does one do to handle this situation? I'm not, if you could help me out, Dr. Athley, I'm not sure. Are certain heart meds associated with memory issues?
I'm not sure that the statement is really well proven. There have been alleged memory problems with some medications. I know that one that came under scrutiny was the whole gamut of statins. These are medications used to help cholesterol for the heart patients, to help diminish the cholesterol. But there's not been any clear-cut documentation or demonstration of a significant effect on the memory from statins. We mentioned beta blockers. That family also came into some scrutiny. But again, long or short-term memory effects are very difficult to document with these. So I'm not really clear that most of the commonly used medications for the heart disease, in fact, do have any adverse effect on worsening memory. Maybe someone else may want to contribute to some of the memory concepts.
Yeah. Yeah. It's a little bit out of my field, Doc. I think we're going to have to leave it there. All righty. Next question. What are food or supplements we should include in our diet to sustain excellent prostate health? Can someone help us out with prostate and what we eat, and if there is any correlation there?
Omar, is this funny? I was trying to type that answer, but you know, I'll say what I understand. But foods that are reportedly anti-inflammatory supplements, such as turmeric, garlic, are touted as being helpful. There are certain herbs like saw palmetto that's been put out there, that's been said to be helpful. The plant steroids, things that are rich in plant steroids, which has multiple other reported benefits, including decreasing cholesterol, are helpful, such as those things are such as flaxseed is known to be helpful. And then, there are certain things from, the homeland that folks have put out there, like the noni juice. I've seen several quote unquote studies, the quality of some of which can be questioned, but it's been out there that they're very good for treating cancers in general, but help with some prostate issues. There are certain other things like the a fruit that I think it's called guanabana or soursop. Both the fruit and the leaf itself, people have said has been quite helpful. So that's just to name a few. There's a litany of things that have been reported to be helpful.
All right.
So, Dr. Anderson, you answering that question as a gynecologist leads me to something that has always been on my mind about what are some of the common urologic problems that your patient base sees. I think it's underdiagnosed, undertreated women with urologic problems. So, could you just give us a couple of seconds or minute on things that you see in your practice?
This is an interesting topic. I think most of the symptoms that are more women experience urologic issues than are reported. Oftentimes when we come in, our questions are tailored to common things that are of the nature of most of the common physiologic issues: abnormal bleeding, discharge surrounding infection, physiologic infection. But urologic issues are important. One, it affects lifestyle in general, both sexual function and urologic function. But what we do know, if you're seeing women who've had multiple vaginal deliveries, especially middle-aged and even some younger women, some of those questions need to be tailored toward urinary incontinence, urinary dysfunction. Oftentimes when we do exams, if the patients are asymptomatic, we often don't tell the patients that, we see some relaxation, some prolapse. And some of these are, from a general surgical standpoint, are pelvic floor hernias, right? Fascial defects. So we see cystoceles where the bladder gets descended further and further down into the vaginal vault because of defect in the endopelvic fascia. We see rectoceles where, the rectum bulges up into the vagina because, again, defects in the fascias of the pelvic floor. The majority of time, these are asymptomatic, but sometimes if not addressed early, so patient can become aware of what might be happening. As they develop, they can become problematic. There are urinary outflow obstruction that, the body has a way of compensating for, but can be a contributor to things like chronic urinary tract infections, and in rare cases can even influence renal function. So it's underreported, but like many other things, once you start to address it, the patient will say, yeah, I've been noticing this, I've been having this kind of feeling. And oftentimes these are conditions that can contribute to chronic pelvic pain, which can affect patients' productivity.
In addition, Omar,
Yeah.
in addition to, in reference to prostate health, don't forget zinc and selenium.
That's right.
Mm-hmm. Yeah, very important, very important. At the cellular level, that definitely is important. I think zinc and selenium is important throughout the body, actually, for cellular health.
Right.
And it helps. Then anyone else? So we're going to go on to the next question. What can cause your vocal cord box to need therapy? Little vague, but we're going to attempt this. Let me. Since I'm a pulmonologist, I'll go through some of the things. I see a lot of patients that come in and they have either sore throat or hoarseness, and they want it evaluated. Some of the patients, even with sarcoidosis, I have patients that have sarcoid nodules on their vocal cords, and they have hoarseness, chronic hoarseness. But there are other things that, that can cause hoarseness. One thing that I find a lot is that patients with lung cancer that are in the upper lobe of the lung on the left side. It's called the recurrent laryngeal nerve. It's a nerve that travels down along your vocal cords. Well, put it this way, it travels down the left side of your chest, and it affects the left side of the vocal cord. So you get hoarseness because of that. When the tumor presses on that nerve, because it comes down that way. It can be chronic cough can cause hoarseness or a vocal cord problem. Polyps, of course, can be there, and they can cause you to have hoarseness or difficulty in speaking. And you can have even a stroke, minor strokes, either TIAs, which is a minor stroke, they call it, or a permanent stroke can cause dysfunction as far as the vocal cords are concerned. And even swallowing, it can cause something called dysphagia, which is difficulty swallowing. And there's just generalized paralysis of the vocal cords as well. Understand that if it's just a paralysis or if it's an inflammatory process that's chronic, sometimes I have several patients that are on Botox and actually get Botox injections in the vocal cords, and it serves them well, and they've done very well with that. If anyone else wants to chime in on this, you know, from a different aspect, but that's what I can contribute as far as vocal cords are concerned.
So with respect to that, Omar, I think it's important that good and thorough evaluation be conducted by an ear, nose, and throat specialist. Because one of the things that can occur, some of which is lifestyle related, one can have HPV-related disease and have warts on the vocal cords. And this, like I said, can be lifestyle and professional related. So, you know, guys like myself who do a lot of lasers, Dr. Stratford, who will do a lot of electrocautery, electrosurgical procedures in the mouth, we need to be aware and mask up with the appropriate mask, because, you know, it's been known that oral HPV cause a lot of the things that we treat, and the plume from some of these procedures that we do, laser or electrosurgical procedures, get into our airway and can cause these warts on the vocal cord. So it's important to really figure out the underlying cause of the hoarseness before, you know, we proceed with just any therapy.
Dr. Clark, I have
a little bit.
Hold on. We got two doctors speaking at one time. Okay. Dr. Aluya, then Dr. Garrison.
Yes. You know, Dr. Anderson just talked about lifestyle changes and the things we've done. For my practice, I've seen a lot of people who have had a history of tobacco use and chronic alcohol use. They're prone to head and neck cancers, especially if you've smoked for a long time or drank for a long time. Sometimes there's, you know, the debate which one causes what the most. But more recently, it's more with, you know, chronic alcohol use. Now, I often tell people this: if you have a hoarseness that's exceeded 2 weeks or more, please have it checked. Please, it's important. Thank you.
You know, Dr. Aluya was reading my brain there, in that I was going to ask Dr. Clark and Dr. Stratford about, one, the increased incidence of vaping, the increased incidence of people with chewing tobacco, and how that has affected oral cancers, thyroid cancers, et cetera, et cetera. So Dr. Clark, Dr. Stratford, please.
I'll let Dr. Stratford go first.
Dr. Stratford, you're still on mute.
Yeah, thank you for giving me that one. But there seems to be a increased incidence of verrucous carcinoma because there are more incidents of I don't know what it is that's causing it. That's not something that I really, you know, I think I referred a few cases to a few guys that actually specialize in that. But you're seeing a higher incidence of I think it's loss of tissue tension around the soft tissue in the mouth. And that kind of is an indication, one, of either hypertension or some sort of tobacco use or vaping use. And so it causes a lot of problems for the periodontist, or for if you're doing like a lot of cosmetic or elective procedures, it causes a lot of gingival recession. And so that tends to offer a new discussion. But then sometimes you'll see something that looks very peculiar. And so I've seen quite a few peculiar lesions lately. And so I've just been really referring to the guys that know better than I would, because I don't see them very often.
Yeah.
Back to you, Dr. Clark.
All right.
I mean, the other thing we've seen is an increase in HPV-related head and neck cancers, as Dr. Anderson has pointed out. And it seems to be the similar strains, or at least some of the similar strains that cause cervical cancer and anal cancer. So from that respect, in addition to chewing tobacco and smoking and alcohol, from that perspective, we have seen an increase in that group.
Mm-hmm. All right.
I think some of the physiology behind that is some of these usage of these chronic substances weakens the barrier of the mucous membrane of the mouth, and similar to the squamocolumnar junction of the cervix. Once the mucous membranes or the integrity becomes weakened, then the ability of these pathogens to enter into the cells become more potent. But also with respect to HPV with the head and neck or the urogenital system, it's the high-risk HPV subtypes, and there are about 9 or 10 of the high-risk subtypes that we see in about 98% of all these squamous cell type cancers, both in the genital tract and the head and neck, 16, 18, 31, 33, 45, those subtypes. And what they do is they actually become integrated into the genes that regulate cell cycle and affect some of these normal cell cycle processes, such as programmed cell death. And as a result, you get these development of these cancers.
Mm-hmm. Excellent.
One of the things Dr. Louis had mentioned, some of these symptoms should be evaluated, especially if they persist. So if you have unexplained neck pain, unexplained hoarseness, unexplained difficulty swallowing that persists, absolutely should be evaluated.
Yes. There's a question. We're coming pretty close to the end of the program, but there was a question that came in that I wanted to cover, and we'll open it up to the general public here, general physician public. Do you think the COVID vaccine will be safe and effective? They want our honest opinion. All right. And can we start it off? Anybody want to start this off? Because this conversation it's just out there. Everyone's asking. There are people that are holding off, waiting until, as many people get it as possible and all their friends get it. So they make sure that if they're all right, then maybe I'll get it. And then there are other people that are jumping up in front, being first in line to get it. So, and you understand our community too, as far as what's happened culturally and from a medical standpoint, with the Tuskegee incident and stuff like that. That is truly ingrained in our culture. And it's not something that can be washed away, and we have to address it. So as a physician group, and all of us being physicians, Black physicians, let's address this question. Would somebody want to start it off? Dr. Garrison.
You have to understand, there's a lot of misinformation there. You have to understand, and when I ask my friends and families why they are holding off specifically, they're talking about, well, we don't know. There haven't been enough people tested. Well, when we look at the studies, there are 50,000 people in these studies. And most studies, when we publish literature and when we print reports of our clinical research, we're talking about 1,000 people, 2,000 people in the studies that we utilize to dictate our medical care. Now, so these are 50,000 people that were tested over 6 months. Also, what happened in the development of these vaccines was the platform to produce the vaccine was already there. It was the new technique in developing messenger RNA, and these two companies came together. And once they coupled the production of the mRNA plus with the platforms to produce, mass produce vaccines, that's how we got to where we are. So the platform was already there. It was already found to be safe and effective. And now it was just developing the specific vaccine for the COVID. And once that happened, the mass production happened. So I have taken the shots. I've had both shots. I've had minimal, if any, symptoms. I had a little soreness in my arm and a little bit of, my family said I slept a lot the day after. Other than that, there have been no side effects. So I clearly advocate, and my libido is still strong. I do not have a horn growing out of the side of my head. And I didn't develop autism. Okay, so I think it is effective and it is safe, and we owe it to ourselves as well as our community to protect one another. And I'm a strong advocate of the vaccine.
Also,
Omar, I just want to make a couple of quick comments. So, by the way, Jordan, your family did say there was a change. You stopped snoring and now you bark in your sleep. So that may just be one change. But to your point, the technology is not new. But there's a part of it that sometimes, you know, it's not always what it is, but how it looks. And for folks need to understand, when major research body like the FDA and people from the CDC starts to put out data, there's a couple of things that goes into the reporting. And it's besides the you know, we talk about safety and efficacy, but how that looks depends on the statistics. So what we know when we design studies to evaluate treatments for illnesses, we look at a concept called power. How do you power these studies? And the power is based on the incidence and the frequency of the disease. So what we do know about COVID and what we've seen about COVID is we've lost a lot of people over a very short period of time. So the incidence of illness, even though they said only 20% of people who get COVID actually gets ill, the fallout is significant. So that said, you kind of don't need a whole lot of people for you to start seeing statistical significance. But that said, you know, some of these studies are well powered. Like Dr. Garrison says, 50,000+ people. Now, how are these studies structured? They're randomized study and they're prospective study, meaning we're not looking back being a Monday morning quarterback. We're taking patients who have never been ill and we're giving some of them the vaccine and some don't get the vaccine. So you have two arms. It's a controlled trial, right? So these are some of the purest statistical analysis that can come from data like this, all right? So it's more believable when someone gets the vaccine, get exposed, and don't get the disease. It's more believable that the vaccine is effective. Now, there will be some people who get the vaccine and get exposed and get ill, right? So then you've got to compare those groups, right? And if one group is way above the other, then when compared to the similar situation on the control side, meaning ones who don't get the vaccine, get exposed, don't get the disease, or ones who don't get the vaccine, get exposed and becomes ill, then you can do the purest statistical analysis that you can do and come up with a term called statistically significant. And based on what we know, the short-term efficacy is statistically significant that these vaccines will at least help prevent serious illness. Now, we didn't say prevent getting infected. We said prevent serious illnesses. So that said, knowing what we know, you get the vaccine. I think most of us on this platform has had the vaccine. You still maintain normal, reasonable behavior. you know, because you can get the vaccine, you won't get ill, but you can infect somebody else.
Right, right.
And that's the basic concept.
Omar,
So Dr. Cord is next. Dr. Cord is next.
Right.
you know, what I do in my office, I say, would you want the vaccine or you want a respirator? And then
Right.
I convince them, and next thing I do is I flash my card to show I had the vaccine and nothing happened to me. I'm still alive. And except for the day that I received the second dose, just like Jordan, I slept for about 10 hours. But here's my proof. I'm still here. And please do what you're supposed to do.
Right.
I think it's really important as us as physicians be transparent. There's a group called NMA, and they've done studies where they've vetted all of these vaccines. And, you know, we know about Tuskegee incident. We're all aware of that. So we've been vigilant in making sure that this type of thing doesn't happen again. And so we're always constantly checking for these things. And so if we feel somewhat confident that this is something that's feasible, that we've all participated in getting the vaccine, that should make you feel a little bit more comfortable. I don't know if it won't ever get that cleared out of your head, but we as physicians have to be transparent and letting you know what we're doing and what's out there, the fact that we went and got it done, and hopefully that would motivate our people to getting it done, because this thing is ravaging our communities. People are scared to getting it done, while the other communities are going out and getting these vaccines. Our people aren't going to get it done. So I really feel strongly about it going, that we've gotten it done. We're letting you know that it's okay to get it done. So you should go and get these vaccines so we can get herd immunity to help get rid of this thing.
Right.
Yeah, and I just want to just here for a second. I just want to say, NMA, you made a statement. NMA is National Medical Association, and that's the National Black Medical Association. You can look on their website and get more information. Who's next? I think
quick answer. Just mention briefly the question of whether or not we advise that people should have the vaccine. I've had it myself. Advise family, friends, and patients. I wholeheartedly advise it without hesitation, because I am aware of the alternative and we don't want to suffer the alternative. Furthermore, by other people not taking the vaccine, they're putting those of us who've taken it at risk, because if they allow continuation and propagation of the current virus and allow mutations to form, then those mutations may in one day be significant enough to affect those of us who are careful enough to go and get the vaccines. So I certainly advise everyone, please get them, save yourself and save us too.
Mm-hmm.
Yeah, you know, and from an educational perspective, you know, Tuskegee happened at a time when, you know, disparate approach to healthcare was rampant. Now it's being highlighted, and no study of this level will get to where it is without oversight, you know, IRB submissions, you know, just scrutiny. And then the other part of it is, you know, as people of color, you know, we're always fearful of participating in clinical trials. And clinical trials are really important. And I think as healthcare providers, whether it's cancer, whether it's hypertension, diabetes, or infectious disease, we should encourage people to participate in clinical trials. And not because I suggest it means you should at least look at it, because there is a whole process of informed consent that has been vetted, typically, that allows you to make that choice and not so much lean on history. And if history means anything, there is Black and brown people who participate in the development of these new vaccines. So, you know, it means a lot, you know, but, you know.
All right, excellent.
Well,
Dr. Aluya.
Yes, I wanted to say this, that I know there are historical concerns that, you know, that's plagued us as a people all through history or for centuries. Just like Dr. Anderson said, yes, they were then, but now it's here. And one of the reasons why we have 11 or 12 of us here right now is because we've become advocates for our community. So if you have Anderson, Clark, you know, Bay, Dr. Atlee, Court, and I, who James and everybody else who are out here talking to you, it therefore means we're standing up and standing firm for our community. Now, the question is, does vaccines work? Yes, they do work. Because I mean, every day, including this morning, I had to talk to people who were concerned. Now, the question is, vaccines work? Because I've asked them, when was the last time you saw somebody with polio in this country? They're like, none. We don't see. Yes, you don't see those things on measles because here we've done mass vaccination and we're able to control that. And now, but in other countries where they don't have this, you still have reports of those things. Now, sometimes they're like, oh, so how about the technology? You know, it's new, we haven't been tested. I like, listen, look at your phone. The phone you used 10 years ago, it's not the same phone you use now. Technology progresses. It progresses on everything, and so also with the technology, how we treat diseases. So it's bound to happen, and this is new. The mRNA technology, yes, it's new, but the story of the mRNA technology actually did start in 1976, where the components to preserve and allow the delivery of the vaccine was actually first written then. And they ridiculed the gentleman who wrote it. I think Dr. Levinson or something like that. He was ridiculed and he was made fun of. And when Dr. Caraco, Catalina Caraco came up with her write-up in 2005, who's Bulgarian, she was ridiculed. Actually, she was actually, like she said, she was demoted because they thought it was a joke. But when the need to treat to handle this pandemic, because a lot of people were dying, people were looking for alternatives and reasons to help save lives. So they reached out to this technology, and that's where we are. So we should not be afraid of technology. Technology is not the enemy of Black people. We should learn to embrace technology because we'll all do well with it. Now, in my conclusion, look, go out there, take the vaccine. It's safe. I've done my 2 shots. If you have any questions, come ask us. Reach out to anybody. You're not going to grow wings. You won't grow feathers in your toes. It's not going to happen. But help save lives, and as we save livelihoods. Thank you.
Excellent, excellent. I think that's a great way to end. So we're going to end this webinar. And I'm going to say, listen, just thank each and every one of you for participating every second Saturday, you know, at 1 o'clock and coming on and giving your, you know, bestowing your medical knowledge, because it's so important for our communities. Understand, as I'm just going to repeat it again, it's every second Saturday at 1 o'clock. All right. I'd like to thank OBHealthy for supporting us, for bringing and allowing us to bring this webinar to you. Remember that they are health and wellness. Check out their app. Just download it. They have a marvelous weight loss app, and it just, you know, it's just something that our community needs as well. The most important thing I can say, and I will say this all the time, do not change any aspect of your medical care until you consult your physician. Remember, your physician is the only one that truly knows the best way to care for you, and you must follow them specifically. All righty. Also, as far as if you want to look at our prior webinars, just go to OBHealthy on YouTube. They're up on YouTube. Please take a look. Enormous amount of information. All righty. And until next time, listen, I just want to say peace and, you know, be safe, be healthy, continue to wear your mask, continue social distancing, and wash your hands every chance you get. Until next time, we'll see you then, and look forward to you signing on at that particular point. All right. Bye-bye, everyone.
All right.
Bye.